Welcome to the latest episode of CarePoints. I'm your host, Kenny Schiff, Chief Marketing Officer for Lone Star Communications, the Alero Solutions Group, and our latest family member, Promobix. Today's episode is part of my continuing series of conversations with my collaborators at Lone Star, customers, partners, and notable folks in the tech industry. Thanks for joining me today, and I look forward to another great conversation with my guest. Welcome back to CarePoints. I'm talking to Amy Clodfelter today. I'm going to have her introduce herself to you, and we're going to be talking about alarm management, bed exits, falls, all those things related to alarm fatigue and what it's like to operate in a hospital from a nursing perspective. Amy's an informaticist, and we'll start by having Amy tell us a little bit about her background, herself, and the work that she currently does at McLeod Health. Welcome, Amy.
Thank you, Kenny, and hello, everyone. Thank you for listening today. My name is Amy Clodfelter. I have been a registered nurse for probably 25 years. I have been formally in informatics for well over 15. I began my career as a critical care nurse and became a travel nurse and really started thinking about all the systems, how they work together. As I worked in several different community and academic hospitals, it really intrigued me to see how nurses were performing work in a variety of different situations and with a variety of equipment everywhere I went. So that kind of drove my curiosity and natural tendencies to systems thinking to get into informatics back in the day of computerized order entry and meaningful use. And I was fortunate enough to move that career into a large organization where I led a team of nursing informaticists and worked on a very broad portfolio of all the technologies that the nurses and other clinicians use at the bedside, including some of the alarm management that we'll talk about today. Currently, I am working for McLeod Health that is in South Carolina. It is a community health organization with a very large facility and multiple rural facilities. They have markets at the coast and also inland of South Carolina. I am leading their telehealth strategies, which is a huge necessity for this organization because of the rural locations of some of their services and also the growing population of retirees moving down to South Carolina and their ability to get transportation and accessibility to all the services that we need. So it's very exciting work, and I'm excited to be here.
Yeah, and I think I'm looking at your profile. You recently were in a doctoral program for health informatics, so you've kind of expanded your horizons.
Yes.
So,
yes. I have my bachelor's degree in nursing, and then I got a master's in IT. And so then I went full circle and got my doctorate in health informatics at the University of Texas Health Science Center in Houston. It was an amazing program. I encourage everyone to look into it. So I kind of went full circle trying to learn and grow in my career.
And teach also, because at the end of the day, it's so much is experiential. Mm-hmm. I was just in Houston last week, and I had not been to the cluster of healthcare institutions that is there, and it was just mind-blowing.
Yes.
The power and capabilities that come out of Houston from a healthcare perspective.
I don't know for a fact, but I think I've heard that there are more health systems kind of in that mile radius in Houston than any place else in the country. So it is a hot seat for healthcare and healthcare technology, yes. And
growing in a great place for you to have cut your teeth, as they say. So I would be remiss to not mention your recent article in CIN, Computers, Informatics, and Nursing. And we'll put the link in the show notes, but the article is Improving Alarm Management Practices, Wireless Bed Exit Alerts on Medical Surgical Units. And it's a very compelling piece and kind of shows Amy's work on the ground off and very thought-provoking. And it led me to want to talk to you. My personal interest around alarm analytics and alarm management and alarm fatigue has been going on for 20 years too. Even though I am not a nursing professional, I've been involved in the support of improving the patient experience and also the staff experience. So I really wanted to talk to you about that because your piece is focused on very real life matters that nurses and nurse informatics and staff in general experience when they work on the floor. So let's just start as a baseline to talk about the problem. All right. So before we started recording, I mentioned that I've been in and around this for 20 years. And we've been talking about it for 20 years, and maybe the needle has moved a little bit. So let's first talk about the problem. So what is alarm fatigue and how real is it?
Yes, well, alarm fatigue is when we are sending signals. They could be, volume alerts. They could be flashes on the EHR notifications, pop-ups, all types of signals. And they become so inundated, they being the end user, that they either can't make sense out of what's true or what's false. And then over time, it's like the boy who cried wolf. They just stop believing or they just stop being able to respond because there's so many and it doesn't fit into their workflow. So alarm fatigue, it's hard to measure, but it's something that's been around and been a problem for decades. In 2013, Joint Commission released a Sentinel alert about the problems that alarm fatigue was causing to patient care and some of the contributing factors like education, workflow design. And so for them to have released that, in 2013, that means there had to be a problem predating that, right? So it has been a struggle. And then the more that we've layered integrated systems now on top of each other, it's just contributing even more exponentially to what our clinicians are trying to decipher at the bedside and take action on.
Yeah, and in many respects, you would have thought it could have gotten better because there are better tools than there used to be. But would you agree that it's gotten actually worse?
I would agree that it is, I don't know if I would say worse, but I think one of the challenges is making sure that you have the data. And so organizations, it's similar to continuous quality improvement, high reliability organizations. When they have a mature structure and they can keep focus on it, it helps them improve. I think the challenge is, one, being able to capture all the data from the systems that you're using and looking at it comprehensively. And now that we're changing to other technologies like AI, those generative bots and things like that, it's another type of signal and information that we may not be accounting for in the data. So I don't know that I would say it's gotten worse. I don't think we ever had it under control. And I think that we're just shifting the way information moves now from system to system, and we've got to take that into account for sure.
So this has been an important focus for you for a bunch of time. What inspired you to focus on this from a research perspective, and specifically the whole wireless bed exit thing as it relates to alarm fatigue?
Sure. Early on in my career at my last organization, when I joined the corporate nursing informatics team, we were implementing secure clinical communications and collaboration platforms, which was necessary at the time. A lot of mobility was the focus, so nurses not being tied to a desktop to communicate or to get access to information on the patient's chart. So I was contributing to a good solution for one use case, but in parallel, as we started taking advantage of the capabilities of that application and the smartphone devices out in the enterprise, we were integrating other types of systems like your call system, your nurse call system, where you press the button if you need toilet, if you need water. And so as we were trying to improve the workflow and efficiency for the nurses, there was a fine point that we got to where too much was going to the phone that didn't necessarily need to. And so that was something that we were able to hear from our end users, hey, stop, we've got enough, let's rethink this, and then validate into the data to say, well, this does look like a lot of noise that we're sending to the nurse on that device. Do we really, really need to be sending it? So I was kind of contributing to the problem, if you will. And so that I had firsthand, knowledge and experience to help relook at that and optimize our solutions.
So since our audience is very varied, let's just define nuisance alarms, because you're talking about signals, all kinds of things, some of which are more important than others, but let's describe what a nuisance alert is and then kind of further go to how that relates to the whole bed exit thing.
Sure. There's a couple different variations in definitions out there when it comes to alarm management, non-actionable nuisance alerts and true positives, false positive. But essentially, a nuisance alert is something that is not clinically relevant to that care of that patient or to that clinician at that time, or that's not actionable. So some examples could be when a patient is wearing equipment like an EKG leads that monitor their heart rhythm. And it will look like there is a rhythm on the screen if one of those leads is loose or off. So that's kind of a false alarm, because it's actually true that something's going on with the patient, but it's not clinically indicating a change in the patient's condition. Another type of a non-actionable alarm would be if you have a patient who's, let's say, a marathon runner, and you've got them on a continuous heart rate device, and their heart rate is low. Well, that's probably normal for them, but the out-of-the-box settings that you get from vendors are built for the average person, let's say 60 to 100 beats per minute, and they might be dipping down to 55. So what we would expect is that a nurse, gets an order and changes those parameters on the device so that 55 isn't alerting all the time, because again, it's not really actionable. So there's lots of things in an environment, in a hospital specifically, but other, clinics and other now patients at home that have these devices that are being monitored at home that can contribute to added noise and alerts that may not be relevant at that time. And so those are essentially what we mean by nuisance alerts, or things that, we can dial back a little bit.
Let's take that a little further and talk about beds. So traditionally, beds, probably for the last 30 plus years, have been interfaceable to call systems. So, and they have varying levels of capabilities of understanding whether the patient has moved or gotten out of bed, etc. So talk about the spectrum of issues around connecting beds to alerting systems and why it could also contribute to nuisance alarms.
Mm-hmm. So this is why I love informatics, right? I think about everything from start to finish when it comes to a workflow. I love to approach things systematically. And when you think about bed integrations, there are lots of points of potential failure. So let's take a patient who is a high fall risk. They'd be in a bed, and we use the bed exit alarms traditionally to make sure we hear if the patient is trying to get out of bed. It's not perfect. A lot of times injuries happen even with the best, intentions of setting alarms. But that patient, that's really the first step, is the bed alarm set? And then you have the integration with the nurse call system. And so typically that's a cable into a wall. They have magnetic, they have Bluetooth now to make it a lot easier and more reliable. But typically you've got a cable into a wall. Those little prongs on the bed cables can get broken easily, especially when you're transporting patients to procedures like CAT scans. And then when that signal gets to the nurse call system, it can alert dome lights outside the patient's room. It has audible sounds outside the room at the nurse's station. And then, as we did, when you layer on another wireless device like a smartphone, you have typically a lot of freedom to configure those alerting pathways however the organization wants to. So for the bed exit alert, for a long time, nursing leaders thought that everyone needed to get those alerts because they were very urgent and needed a very quick response on it. It's different from getting somebody a cup of water, for example. If somebody's trying to get out of bed, we need to be there really quickly to get that patient back in bed and prevent any falls or injuries otherwise. So in theory, hey, let's send it to everybody, because if everybody gets it, that dials up their sense of urgency. Well, come to find out, that's not really, again, what happens, because that's that alarm fatigue. That is the truest definition. Everybody's getting it, and so nobody knows who's responsible, if you will, for going to that patient first. And everyone knows the nursing staff, they're typically busy. What if I'm in a room with a patient doing a procedure? What's the expectation when I get that alert on my phone? Am I to drop everything? Is the whole unit supposed to drop everything? So there was a lot of culture that we needed to shift and thinking behind that design.
And it impacts staff, but it also impacts patients. So let's say there's somebody who has a nuisance bed alarm go off in the middle of the night that goes to everybody. That can impact the patient rest, etc.
Yes. And these beds, the beds have gotten more sophisticated, just like the other technologies that you and I interact with. It's not the old metal frame beds where you just put the bed rail down. I mean, there's pressure sensing mattresses now. So there's settings for if the patient just shifts a little bit, like if we were going to reposition them on some pillows, if they move a lot of their body weight, like if you were turning them for a bath, and then it can detect if they're actually got their feet out of the bed. So knowing how to use the beds is also a contributor to the number of alerts that are going off, being set off. If a patient's family gets a patient out of bed because they're trying to help out the staff, that's another situation where, hey, it's not as critical, but we need to educate people, the family members as well.
Yeah, and how all these things go together is fairly complex. So there's no one magic system that brings all these things together. So let me, in your journal article, you talk about socio-technical factors. So let's define that a little bit, this kind of human technical dimension to all of this, and talk about its contribution to alarm fatigue in a busy hospital unit.
Yes. So Dr. Siddiq and Dr. Singh have done numerous research articles on their socio-technical model, which is eight domains. Some examples are workflow and communication, hardware and software, the people, the internal regulations, the external regulations. So all of those things get evaluated in an end-to-end workflow from a systems perspective. And so, some of the things that we found when we did our workflows and observations were related to the different factors. So that's how I just started looking at them. Did we cover everything? It's a really great approach, not just for informaticists, but for others to go when they go in to do any sort of root cause or process improvement. And so when you think about it, we looked at everything start to finish, rounded with the nurses. We kind of tried to categorize, but sometimes there's an overlap in, is this a workflow issue? Is this a software issue? Is this a policy issue? So we didn't get too prescriptive in which domain does it fit in, but it helped us understand, did we cover everything? Is there something that we're missing? And as you said, socio is human, technical. So the people, the process, technology, that's what we wanted to evaluate when we went in to see what was causing the issues, and then what could be potential solutions to those issues.
So did you have any ahas? Which dimensions did you find most critical, you think?
I would say for this particular work, there were three. The workflow and communication is one factor. So as I kind of mentioned earlier, when you're sending information to everyone, what is the expectation on who's responding? How do they know that Kenny is already in the room? when Kenny and Amy are both getting that information or that alert. So that was something we really needed to tease out. What is the expected workflow? What is the expected communication? That then plays into the policy. So as you're developing that, you want to make sure that your policies help address and support that. So one of the things that we've utilized, and I think it's common for nursing in the industry, is kind of like a no pass zone. So again, there's alarms, there's noise, there's lights outside the room. So how do we re-emphasize this approach where anybody walking through when alarm's going off, especially an urgent alarm like bed exit, is able to go in there, feel empowered to see what's happening, clinical or non-clinical. And then the third one for us was the software portion, software and hardware. So making sure that, again, the equipment was not broken, that anything we could do to alleviate those false alarms from loose wires on the beds or, that type of thing, plus the configuration of that escalation pathway in the nurse call system. That's really what was controlling who gets this alert and on what type of device, either a light outside the room or a mobile device.
So there ends up having to be a collaboration that involves multiple disciplines, including the vendors, people like clinical engineering, biomed, whoever it is that's responsible for workflow and the kind of alarming infrastructure, nurses on the floor, management teams, et cetera. So you did your work initially for this study in an 815 bed magnet facility, and there were interventions that you did. So it seems that at least one of them was potentially reconfiguring the workflow based on your observations. Do I have that right? And are there other specific interventions that you ended up making happen?
Correct. Yeah, we created a list of what we thought were, recommendations that we took to nurse practice councils and to the hospital leadership. Some things may not be financially feasible in the short term. Let's say you have 3 or 4 different bed types in your hospital, especially larger facilities like that replace things, over a certain cadence. It may not be financially feasible to just say, hey, we want to make every bed the same so that we can educate easier. So those are things that you can think about for a strategic long term, but might not be a short term solution. So we came up with a lot with the nursing council. What are things that could be education based? Do people even know how to arm the bed? Do they know how to change the weight settings? So we created refresher trainings on that. We also walked through that, again, escalation pathway. So asking questions like, okay, well, you're getting it. What do you do with that information? So really teasing out the what ifs and what then situation to bring everyone to say, where should we be targeting and tailoring these alerts so that everyone knows what to do with that information?
So in the end, some agreements were made about what to do, and yet where the rubber meets the road, it's the frontline staffs, it's the nurses, unit managers from both a design and rollout perspective. So were there things that were done to specifically engage that staff to make them feel empowered, make them be part of the solution, et cetera?
Yes, the frontline staff were engaged from the beginning and throughout the whole project. So again, because it was a magnet facility, there were already a culture of research-based, evidence-based projects, and the awareness and appreciation for process improvement with nursing councils. So that was a really great thing to already have in place there. And I would say that we, use them for their feedback. We use them for their observations. We asked them about certain solutions and they said, we don't really think that's like an issue right now. And once we went live and rounded on our pilot units, we ensured that we had data on the ready that we could present to them the first week to show the impact, because that's really important, right? Oh, let's go make a change, but how is that impacting them? A single nurse may say, yeah, I noticed, or I've got some perceived awareness that it changed. But when you put the numbers in front of them, when you survey them about their experience that week and ongoing, it really helps them feel engaged, and that you're supporting them on the long term with that. So it was really important to have that data up front to show that this actually is a problem, and then to show how meaningful those changes were.
Were there any issues with cooperation? Were there challenges in terms of making this sustainable over time?
No, there was no resistance. Again, when you put the data in front of, especially your executive leaders, and they hear things, right? Yeah, we think that we have a problem with a lot of noise on the phone. But when people see numbers and facts, it's like eye-opening that there's an opportunity there. And then immediately, once we saw the drastic reduction in the number of alerts going to the phones, they were like, this is great. The nursing leaders on the units even said, it's so much quieter. I can't even believe it. It was immediate. So we knew that we had a fast win that we could explore on other units and other facilities. It was much needed and much appreciated by those end users.
So obviously you have a passion for data. You're an informatics geek in your own way. So there were some significant reductions, and there are specific metrics that told you that both demonstrably to yourself, so that you understood the validity of the work that you were doing, but also, as you just pointed out, that created awareness at a management level, but also from a frontline staff perspective. So can you share some specific examples of metrics that really stood out to you?
Yes. So when I started evaluating, what we could do to address this outlier, right? When we started with the data, we didn't know that the bed exit alert was necessarily a bad thing. We just knew that it was producing the most signals compared to other workflows, like the toilet, the water. So in that system, we just started there. And then when we did our observations, we validated that, yep, this is not necessary to be going to everyone. So that's how we started with our data. Then I spent a lot of time with my engineers, my product teams, understanding what other types of data we could be getting from these systems. Like, what else are nursing leaders looking at, or should they be looking at? Are we responding timely to the patient? So we looked at response times. We looked at things like a false alert. So if a bed alarm goes off and then it's canceled within 10 seconds, is that really a true alert, or is it just the physical therapist did not turn the bed exit off before they got them out of bed? So we started thinking about ways in the workflow of what the data was representing. And then, the problem that a bed exit's trying to solve is fall prevention. So we were pulling data again to make sure we had it so we could measure it before we started down the implementation. So looking at fall data, looking at trends. Sometimes census can impact the number of bed exits you have, because you're just setting more. You have more high fall risk patients. You could have a unit where they set it on everyone at night. So there were different variations and trends we wanted to look at month over month and over the year to see how they fluctuated. So we went with that, and then we looked at the counts. And then we did see a specific reduction in the counts of the wireless alerts, and we didn't see any changes in our fall rates. We wanted to make sure we weren't causing any unintended consequences when we implemented these solutions. And just for some background, I think I kind of forgot to mention this, but we did the pilot. This work was done on 3 different units. They were med-surg units, and they all averaged the same nurse productivity and bed size, but they had like a low, medium, high when it came to alert counts. So we wanted to kind of compare what the units were doing from a practice perspective and what impact we were going to be making when we made these changes.
All great stuff, and creating that fabric of data support for these types of initiatives, it's so important because it allows everyone to have a common understanding of the story. Now, so every scientific study has hypotheses and you put it under controls, but typically there are unexpected positive outcomes. So, like clinician satisfaction, less alert fatigue, etc. What were some of the unexpected positive outcomes that you experienced in this study?
Well, I think taking a step back, we've already talked about the obvious, reduction in noise in the environment. So again, alarm fatigue isn't just the amount of environmental noise, though that's important. It's just the information and understanding what I need to do with it and how I should be taking action. But taking a step back from that, I would say that some of the unintended consequences or unexpected positive outcomes were that we were creating a focus on this. No one had given this the attention I think that it needed to organizationally. And so we were hopeful that this would create change, and it did. And it created a way that we could demonstrate that this was the right path to follow for all the other facilities in the organization, and gave it like executive leadership awareness that this was something we needed to put focus on. And it, again, it brought together, as you alluded to earlier, a lot of cross-functional teams, right? When we make a change in one system, there could be impacts to another. And I think that's something that all of our hospital staff, our biomed, our IT have to be super cognizant of, especially in this day and age with APIs, all the third-party integrations and the interfaces, is that you may be tweaking a server here. We need to be sure that it's not breaking something on the other side that's patient care facing. So it brought us all together, and I think it gave attention where attention was due.
So this work obviously yielded a lot of positive outcomes. How do you ensure that improvements like this are sustainable over time? So that, in this case, you had 3 pilot units, very controlled, but one would imagine this is now rolled out across the facility or broadened. How do we make this kind of effort sustainable?
There's, when I was doing my research, there's several maturity models that exist today. There was one by Carnegie Mellon that was really focused on software development. And so people have applied that to alarm management itself. And some of the key factors, you have to have sponsorship. So your executive leaders have to appreciate that this is a priority and that there's a need here. Or governance, a lot of people shy away from having a strict governance, but oversight over how you implement technologies. And again, that ongoing caring, watering, feeding them to make sure that things are working in the workflow as you intended them to go. And then obviously we've said data, the more that you're able to get in the data, understand it. And I don't think that organizations have to look at the same dashboard every day. But I do think having a regularly scheduled cross-functional team that keeps a pulse on those data points is what sustains it. And in listening to your staff, some old saying, where there's smoke, where there's fire. I mean, if enough people are, if you're surveying your staff to see what you can do to help, what's broken, what needs to be fixed, they'll tell you nurses typically are not shy about expressing their needs.
So we live at a very interesting time in that we understand a lot more than we ever did before. There's been a lot of work, like the work you have done, to specifically manage and address things, especially within the constraints of the existing technology capabilities. But there's many new things percolating. So looking ahead, what emerging technologies, frameworks, or strategies, perhaps including AI or some level of advanced analytics, are you most excited about? And how does this play into the future potential of the work that you have done?
Yes, I'm so happy that there's a focus on interoperability. It's been a hype word for a long time, but making sure that all of our vendors are working together and following, coding language suggestions and that sort of stuff for the semantic interoperability is key. I think there's so much potential for alarms. So again, AI, the hot topic of the moment here, and a lot of potential there. Some of the things where I see that working in the favor of alarm management is being able to train and tailor these alarms based on the patient condition. So as I mentioned earlier, nurse has to go in and change the parameters for a marathon runner so that they don't keep, alarming at 55. Well, that's extra steps for that nurse. They got to call the doctor. So is there a way, and I know there is, but there's the technologies there to read the patient's chart, right? And kind of start tailoring and learning that this is a normal heart rate for them so that the nurse doesn't have to go in every time there's a new patient and reconfigure that alarm settings. I think also just being able to recognize over the continuum of care of a patient while they're in like a hospital setting, for example. So again, using telemetry as an example. Well, here's a run of VTAC. Okay, great. That's very episodic and you can tell the nurse, but the nurse tonight or tomorrow is not going to know that has necessarily increased over time, that the frequency of those runs has not increased. And so that's where I'd really like to see the technology help inform the clinicians on what has been happening with the patient and not just that episodic, here you go, now you figure out the rest of it for yourself.
Yeah, and there's an enormous amount of potential for predictive capabilities. So one of the difficulties of the more mechanical analog ways of paying attention to bed exits, as an example, is that it's, in spite of the beds getting better, there's a insensitivity, if you will, of that capability. And it doesn't tell you quickly enough that something is going to happen, and it doesn't understand enough about what's going on. So ambient room sensing of varying kinds is for sure an emerging thing. And this all, of course, applies to the work you're doing now on telehealth, because now where the patient is might not be in a classic acute care hospital, right? So some of this type of capability and listening, et cetera, has to migrate to the home.
Yes, it sure does. It sure does. And again, no matter what workflow I've worked on, in the last decade, for example, the communication between the 2 points, be it the nurse and the patient, the provider and the patient at home, the virtual nurse and the bedside nurse, that communication loop and how easy it is to understand who to send information to and what to expect to get back is usually one of the biggest, rubs, if you will, one of the big friction points. So anytime that we can use technology to make that easier and relieve that burden, it's going to be a win, no matter if it's bed exit alarms or remote monitoring using telehealth services at the patient's home.
So it's been wonderful talking to you. Did I not ask you something that I should have asked you?
Kenny, I think you've covered it. I don't know if I have much else to say right now, but I've really enjoyed the conversation.
So it's been a wonderful conversation, and I think you've illuminated the work that you've done in such a way that a lot of different kind of people would understand it. And I'll just leave you with this. So you're feeling hopeful about what's possible in the future?
Oh, yes. We've got to stay hopeful for the future. And there's There's so much exciting new things to do. But again, I'll still be using the same socio-technical approaches with the old legacy workflows as I will with the new, ambient AI workflows. So I encourage everyone, if they've not read the research by Sittig and Singh, to look at that and apply that to their daily work.
All right. Thank you so much. It's been great chatting with you, and perhaps we'll do this again about telehealth.
Yeah, perhaps we will. That'd be good.
All right. Thank you.
Thank you, sir. Have a good day. Bye, everyone.
Thanks so much for joining us today on CarePoints. I encourage you to hit the like button and subscribe so that you can get notified when we release our next episodes. Make sure to subscribe on your favorite podcasting service, Apple, Spotify, iHeartRadio, whatever your favorite platform is. And make sure to visit us on the web at www.lonestarcom.com/podcast. That's www.lonestarcom.com/podcast. You'll find all of our old episodes there. Thanks so much for listening, and looking forward to having you back soon.